Hello guys, so let's discuss these MCQs. Question number 1, all of the following statement regarding bioavailability, one of the important topic, bioavailability of a drug are true except. The question is about the bioavailability and the question is about the true except. It means they are asking about the false statement. Which is the false statement out of these? Let's see one by one. It is a fraction of administered drug that reaches the systemic circulation in the unchanged form. So that is absolutely correct because bioavailability means this only. If bioavailability means it is the fraction of the total administered drug that is reaching to the systemic circulation in the unchanged form. So that is absolutely true. Option B, bioavailability of an orally administered drug can be calculated by the comparing the area under the curve. This is one of the important parameter, area under the curve after oral and IV. Yes, it is the ratio because in IV bioavailability we are aware it is 100%. So in every route you can compare with the IV. So that is also true. That is also true. You can say oral bioavailability divided by the IV bioavailability will be equal to area under the curve for oral divided by the area under the curve for IV route. Right? So in IV you know the 100%, so then you can easily calculate the oral bioavailability. The third is low oral bioavailability always and necessarily means poor absorption. No, that is not correct because low bioavailability, that means what? Bioavailability is depending on two factors. One is absorption, it is directly proportional to absorption, and second is pre-systemic metabolism. Pre-systemic metabolism. It is inversely proportional to pre-systemic metabolism. So bioavailability depends on these two factors. If the absorption is more, bioavailability will be more. If the first pass metabolism is more, bioavailability will be less. So low bioavailability. If the bioavailability is low, that means either the absorption is low or the first pass metabolism is high. It is not always and necessarily means poor absorption. It is depending on two factors, not only poor absorption, it is also depending on the first pass metabolism. If the pre-systemic or first pass is high, then also bioavailability will be low. And the last option is bioavailability can be determined from the plasma concentration or urinary excretion data. Yes, I told you about the graph. So we are using the graph between time versus plasma concentration. So you can use this graph which is between the time or plasma concentration. You can also use the graph of excretion versus time curve as well. And our aim is to check the ratio in different route. So suppose one drug is given via IV or oral, you can compare this. So this area under the curve is important. AUC. This is area under the curve and that is determining the bioavailability. So all these are the important points regarding the bioavailability. Option C is absolutely false. Then comes to next question. Question number 2. Urine alkalinization agents are administered in case of poisoning due to drugs which are. So guys, normally if you see our urine is mild acidic. Urine is acidic in nature. So what happens? When the mild acidic drugs are used, we don't use the strong acid, strong base. So that is out of the choice. Now we are using the weak acid or weak base. Suppose we are using the weak acidic drug. When we are using the weak acidic drugs, these are like aspirin, barbiturates. When we use these type of drugs, they can reach to urine as it is, and they will try to excrete from the urine. But because urine is acidic in nature, these drugs are acidic in nature, so there will be more unionization. There will be more unionization than the ionization process, and unionized form is not easily excreted because they are easily absorbed. It is going to be absorbed, so it is not going to be excreted from the urine. Every drug, if converts to unionized form, it is not easily excreted because unionized, you can see, they are easily absorbed. So now what is our aim? Our aim is to convert this to opposite, means more ionization. So how to do that? In these cases, we use the soda bicarb. Soda bicarb, that is alkalinization of the urine. So urine alkalizing agents like sodium bicarbonate injection, they are used in the treatment of weak acidic poisoning. Now you can see strong electrolytes are not used because they are ionized in all medias, whether it is acidic or basic, right? So they cannot be excreted easily. Only weak acid or weak base, these are basically having the role. So weak acidic may use the alkalinization of urine, or in the weak base, acidification of urine. So that is the treatment. So in aspirin poisoning, barbiturate poisoning, soda bicarb is the drug of choice. Right? So that is the correct answer. Soda bicarb injection. Then comes to question number 3. The best drug to start to control BP in pheochromocytoma patients before surgical excision of the tumor. See, pheochromocytoma is a tumor. It's a tumor of suprarenal mass. It's a tumor of adrenal gland. Suprarenal, kidney के ऊपर. Basically, catecholamines are there. So catecholamines secreted in the plasma, the BP will be high. Now, what is our aim? To control the BP and then go for the surgical excision. So what is the drug out of these we are using for this controlling the BP in these patients? Clonidine, that is alpha 2 agonist. Tolazolin, that is alpha blocker. Enoxabenzamin, that is also alpha blocker. And atenolol is the beta blocker. So in these type of patient, when the BP is high, we use the alpha blocker first. We use the alpha blocker because if you see the adrenaline, the BP graph is like this. The BP graph is like this with the adrenaline. So this is adrenaline and the BP is like this. Initially the BP is high and then the BP in the last it will be low, but it is slight fall, not the significant. So this is due to alpha receptor and this is due to beta 2. Beta 2 causing vasodilation. So in these cases, mostly we need the alpha blockers. We need the alpha blockers to control the BP. If required, then we will use the beta blocker. But the first choice will be alpha blocker. When we use the alpha blocker, this option is out and this option is out. Now we have these two options, tolazolin or phentolamine. Tolazolin or phentolamine, these are faster. They are faster and shorter acting drug. They are faster and shorter acting drug. But phenoxybenzamin, that is long and slow. There is longer and slower acting drug. That's why out of these, phenoxybenzamin is the choice before surgical excision. But suppose during surgery, if there is leakage of catecholamine and sudden rise in BP occur, then we use the phentolamine. Tolazolin is not commonly used. Phentolamine is commonly used then. Phentolamine in these cases. But before surgical excision, we only use the phenoxybenzamin. During surgical excision, during surgery, we can use the phentolamine. Now, if suppose you give the alpha blockers, what will happen? These alpha blockers are causing vasodilation, beta 2 itself causing vasodilation. So this patient will have the significant fall in BP. And this is called as vasomotor reversal. This is called as vasomotor reversal of Dale. So what to do? In these cases, we need to give the beta blockers. So after giving the alpha blocker, there will be vasomotor reversal of Dale. So then you need to add the beta blockers. When you add the beta blocker, it will be reversed. So that is reversal of Dale. Right? Reversal of vasomotor reversal, vasomotor reversal, reversal of vasomotor reversal, or you can say it is the re-reversal. Re-reversal. So this is important. That's why in these patients first use the alpha blocker followed by beta blockers. पहले alpha blocker use करो फिर beta blocker. So alpha blockers में phenoxybenzamin is best. Pentolamine is only for emergencies. Then comes to question number 4. Which antihypertensive drug is not safe in elderly patients? Which antihypertensive drug is not safe in elderly patients because of risk of precipitation of asthma, bradycardia, and heart failure. So antihypertensive drug not safe in elderly patients because it can precipitate the asthma, bronchoconstriction. Beta 2 receptor blockade can cause the bronchoconstriction. Bradycardia, beta 1 blockade can cause the bradycardia. Heart failure, beta 1 blockade can cause the heart failure. In old patient, antihypertensive causing this problem is beta 2, beta 1 blockade. So indapamide, that is diuretic. Amlodipine, it's a calcium channel blocker. And guys, calcium channel blockers are safe, they can relax the smooth muscles. They are safe in asthmatics. They are not causing bradycardia. Indapamide is thiazide's diuretic. Propranolol is a beta blocker. And enalapril is the ACE inhibitor. You can see out of these beta blockers, see, it's a non-selective beta blocker. Propranolol is the non-selective beta blocker and it can cause all these problems, especially bronchoconstriction risk is then with the non-selective beta blockers. So the answer will be propranolol. So don't use these in the asthmatic patient. Cardioselective are safer, not the propranolol. So this is about the question number 4, where the risk is there due to non-selective beta blockers. Now comes to which beta blocker is having short half-life because of hydrolysis by esterase enzyme. Hydrolysis by the esterase enzyme in the plasma. So basically from the RBCs, we have the esterase enzyme in the RBC that coming to plasma and causing the inactivation of some drugs like esmolol. So esmolol is the shortest, but it is the fastest acting. Esmolol is the shortest, but it is the fastest. In emergency, we use the esmolol only. In emergency, we use the esmolol only. But nadolol, remember, is the longest acting beta blocker. Nadolol is the longest acting beta blocker and it is contraindicated in renal failure patients as well. It is contraindicated in the renal failure patients as well. So it is esmolol which is the short and fast because of the esterase enzyme from the RBC. Nadolol is the longest acting. Nadolol is the longest acting. Most cardioselective will be nebivolol. These are some important direct question from the beta blocker. Next, after taking some drug for acute attack of migraine, a patient that develops nausea, vomiting. He also developed tingling and numbness in the tip of fingers, and that also turned blue. To increase nausea, vomiting, as well as tingling, numbness at the tip of fingers. So guys, in this tips, we have the serotonin receptor. It means this drug is acting on serotonin receptor. This drug acts on the serotonin receptor as agonistic. There is nausea, vomiting. So these drugs are also acting on the dopamine receptor. So dopamine receptor acting drug, serotonin receptor acting drug. So this is turning the blue. That means there is vasoconstriction. Which of the following is most likely implicated in causing this problem? So which drug is this? So guys, the drug used for acute migraine. So in acute migraine, we can use the NSAIDs like aspirin is not commonly used, but we can if required. Sumatriptan, yes, for good. Dihydroergotamine, yes, ergot compound. Morphine is not commonly used in migraine patients, not a common drug. So out of these ergot compounds are causing the nausea, vomiting, as well as they cause the tingling, numbness at the tip of finger because of the this gangrenous or cyanosis symptoms. So this is typical vasoconstriction by the ergot compound. And what is the treatment for this? We need the strong vasodilators. Need the strong vasodilators. The ergot compounds, that is the risk. This is called as ergotism. This is called as ergotism. That's why they are contraindicated in the peripheral vascular disease patients. This is the reason. They will develop the gangrene if you will not control. We use the vasodilators like sodium nitroprusside, or we use the nitrates. And these are the vasodilators, calcium channel blockers. These drugs can be used in this patient. That's why triptans are the best option. Then, all of the following drug mechanism of action is true except. Let's see one by one. Triptans. Triptans are acting on 5-HT, 1B, 1D as agonist. Yes, because the cerebral vasoconstriction, and that is absolutely true. Metoclopramide is 5-HT4 agonist. That is also true. Metoclopramide is 5-HT3 antagonist. That is also true. Because metoclopramide is having 3 action. It is D2 blockade, 5-HT4 stimulatory, and 5-HT3 blocker. 5-HT3 blocker. All these 3 actions are there with the metoclopramide, which is used as antiemetic as well as prokinetic drug. Buspirone is 5-HT1A antagonist. No, that is not correct. Buspirone is 5-HT1A partial agonist. This is the 5-HT1A partial agonist, and which is presynaptic receptor. Because it's a presynaptic receptor, so it is acting like a brake. Presynaptic receptor, so it is acting like a brake. And because of that, because it is acting like a brake, it will decrease the serotonin release. It will decrease the serotonin release, and that's why it can control the anxiety. But this will take at least 1 to 2 weeks. That's why it is only and only used for chronic anxiety. It is not used for acute anxiety. That is the buspirone. Then comes to all are true regarding acetaminophen except, means they are asking about the false statement. False statement. So acetaminophen or paracetamol. Acetaminophen or paracetamol. And acetylcysteine used in overdose. That is correct, because N-acetylcysteine is the antidote. It is the antidote for this. Analgesic with least anti-inflammatory, that is also true. They have almost nil anti-inflammatory effect. Which is hepatocellular necrosis, that is also absolutely true. This is centrilobular necrosis. This is centrilobular necrosis. Centrilobular necrosis with periportal sparing. With periportal sparing. Centrilobular necrosis with periportal sparing. Phenacetin is the active metabolite. No. Phenacetin is the prodrug. Phenacetin is the prodrug, not the active metabolite. Phenacetin converts to paracetamol. It is not the active metabolite. Paracetamol is the metabolite of phenacetin. उल्टा दिया हुआ है. So this is the option, correct option D. Phenacetin is not available in the market. It is withdrawn from the market because of the nephropathy. Paracetamol is available. Paracetamol is available. Then comes to a 3-year-old child, very young, present to the OPD with symptoms of influenza. Aspirin is contraindicated in this patient because of, if you use the aspirin in children, very important, if you use the aspirin in children, mostly you will see the less than 12 years children, or in the viral infection, especially viral infections, there is a risk of Rage syndrome. There is risk of Rage syndrome. Rage syndrome risk is there. The safer option is ibuprofen. Ibuprofen is the safe option in children. Aspirin is not safe because of the risk of Rage syndrome. That is hepatic encephalopathy. That is hepatic encephalopathy. Right? So that's why aspirin we don't use in the fever, viral fever especially. In children, in viral infection, don't use aspirin. In children or in these patients, ibuprofen and paracetamol. These are the safe option. Next question. A college student is brought to the emergency after taking an overdose of a non-prescribing drug. This is not presenting. Non-prescribing drug. It means without prescription he has taken the medicine. The patient is confused and lethargic. He has been hyperventilating as well as dehydration. Arterial blood gas analysis demonstrate the metabolic acidosis. Hyperventilation means respiratory alkalosis, and this is metabolic acidosis. To manage this condition, it is not likely to be any therapeutic value. So, beta, over-the-counter medicine, over-the-counter, out of the OTC medicine, we have limited medicines. Out of these, aspirin is the drug which can cause all these problems. Aspirin causing hyperventilation, dehydration, aspirin causing CNS symptoms, aspirin causing the acidosis as well. So, what is the treatment option? Alkalinization of the urine, yes, that is the treatment of choice. Correction of acidosis, yes, that is true. Gastric lavage, yes, that can be done. Treatment with acetylcysteine, no, that is not correct. Acetylcysteine is used for the treatment of paracetamol poisoning, I told you, neck, not for aspirin poisoning. Aspirin poisoning में इसका कोई role नहीं है. In the aspirin poisoning or analgesic poisoning, it is not used for aspirin poisoning, it is used for paracetamol poisoning. Next, rasburicase is a newer drug used in the gout. It acts by. So you can see the name uricase. It is the uricase. And what is the role of uricase? Rasburicase and pegloticase. These are the recombinant uric acid oxidase enzyme, which is called as uricase enzyme. Uricase. And convert insoluble uric acid to allantoin. So this is the enzyme basically which convert the uric acid to allantoin. This is the new drug. So it decrease the urate synthesis? No. That is allopurinol. That is allopurinol febuxostat. Allopurinol febuxostat. Increase the urate oxidation? Yes, it is increasing the urate oxidation because it is the uricase enzyme. Decrease the intestinal absorption, increase the renal excretion? No. These are uricosuric drugs like propionic acid. So B is the correct answer because rasburicase, pegloticase, they are increasing the uric acid oxidation. Increasing the urate oxidation, that is the correct. Now comes to same with the pegloticase also. Then comes to next question. Which one of the following is not an adverse effect of ACE inhibitor? Not an adverse effect. So guys, cough, that is true. Hypokalemia, that is false. Angioneuritic edema, that is true. In rash, that is true. Because these ACE inhibitors, they increase the bradykinin. Increase the bradykinin. And due to increased bradykinin, there is inflammation. That can lead to cough, angioneuritic edema, skin rash, all these are there. Dyspnea, angioedema, rash, and urticaria. These are the common symptoms in with all the ACE inhibitors. So these are the adverse effects. Hypokalemia is not seen. Hypokalemia is not seen. Hyperkalemia is seen because all these RAS pathway inhibitors, are causing the hyperkalemia. चलिए. Next question. Which one of the following antidotes is used in the treatment of calcium channel blocker poisoning? So in calcium channel blocker, we use the calcium gluconate. In magnesium toxicity, as well as calcium channel blockade toxicity, we use the calcium gluconate injection. Right? The calcium is basically important in these patients. Or if needed, then you can use the glucagon. But glucagon is the drug of choice for beta blocker poisoning. Glucagon is the drug of choice for Beta blocker poisoning. Calcium gluconate is the drug of choice for calcium channel blocker poisoning. This is important about the antidote for calcium channel blocker. Calcium gluconate. Calcium gluconate. Same with the magnesium toxicity also. Drug of choice. Next question. Drug of choice for ventricular premature beats due to digitalis toxicity is diphenylhydantoin, quinidine, amiodarone, verapamil. So ventricular premature beats are there. PPVs are there due to digitalis toxicity. So what is the treatment for digitalis toxicity? Lignocaine. Lignocaine is the drug of choice for digitalis toxicity. If not in the choice, then we can use the phenytoin, same group of drug, phenytoin. So phenytoin is an alternative to the lignocaine for the digitalis induced ventricular arrhythmia. Important question. In the digitalis induced ventricular arrhythmia or in the acute MI ventricular arrhythmia, we use the lignocaine phenytoin. In rest of the condition, we can use the amiodarone, etc. But in digitalis toxicity as well as acute MI, myocardial infarction, in these two conditions, we need the lignocaine phenytoin. Otherwise, we can use the amiodarone. Then, very important drug, AGT-MIB acts via. Is the drug approved for cholesterol control? It enhances the excretion of bile acid? No. These are bile acid sequestrants. Decrease the absorption of cholesterol? Absorption of cholesterol? Yes. It is basically interfering with the cholesterol absorption from the intestine. We have the NP1C1 enzyme in the intestine, and that is blocked. It is interfering with the absorption of cholesterol. Inhibiting the HMG co-reductase, no, these are statins. Inhibiting the lipoprotein lipase, no. So that is the decreased absorption of cholesterol. That is AGT-MIB. So the answer is not D, the answer is B. B. And it can be given with the statins also, AGT-MIB. Interfering with the cholesterol absorption in the intestine, and they can be given with the statins. Which one of the following for opioid-induced constipation, OIC? Opioid-induced constipation, I told you, constipation where there is no tolerance. Constipation where there is no tolerance, otherwise most of the actions of opioids are having the tolerance. There is no tolerance. So now constipation is there, so we have to give the peripherally acting drug. So both these drugs, albumin as well as methylnaltrexone, both are approved for opioid-induced constipation. Why? Because both are peripherally opioid, peripheral opioid antagonist, albumin and methylnaltrexone. So both are correct, right? Because opioid-induced constipation has to be correct. It is not tolerance continuously there. So this is about the albumin and methylnaltrexone. Important question, albumin. So this is about the opioid-induced constipation. And that's all about this chapter or this paper. Thank you.